And again, for primary insomnia, once you've ruled out everything else, if you did take the time to rule out everything else, how about oral form of Lorazepam? Can that be used on a short-term basis?
It can be used for a short-term basis, again, for patients that have some underlying secondary reasons like underlying psychiatric issues like anxiety. It can be used, but the problem there is with that drug is very highly addictive, and use beyond 3 to 4 weeks can really have an addictive nature to it, and it may be very difficult to really get patients off.
You're specifically talking about Lorazepam?
Particularly, yeah.
It's a highly addictive drug?
That's correct. I mean, benzodiazepines in general are, and that's why I mentioned in general that our first line of therapy are the benzodiazepine receptor agonists, those drugs that I mentioned, the 3 earlier.
Thank you. And then in this instance, Dr. Murray's own admissions that he was administering both midazolam and lorazepam in conjunction, of course, with diazepam and propofol, but the lorazepam and midazolam by intravenous administration. You characterize that as an extreme deviation from the standard of care, correct?
Right, for the treatment of insomnia, absolutely it is, yeah.
And particularly in the way he was doing it via IV administration.
Route, absolutely.
Let's talk about then, you've talked about the benzodiazepines that Dr. Murray was using. Let's talk about your findings in regard to using propofol, specifically propofol for the treatment of insomnia. Is that in any way accepted or appropriate?
No, it really has no role for the inpatient or outpatient management of insomnia. There's really, it's really inconceivable to use this drug for that purpose. It utterly has no role in the management of insomnia.
You indicated that's regardless of the setting.
That's correct.
And in your findings, you state that the mere thought of considering propofol as a treatment option for insomnia is beyond comprehension. It is frankly disturbing. Why did you make that statement?
I think if you just step back and just look at this for what it is, and if you're just saying that here you have someone that you're diagnosing with really bad insomnia, particularly understanding that there are major secondary causes, and to be treating them with a potent anesthetic that has no proven role in management of insomnia is just really hard to really grasp. It's inconceivable.
And you state unethical.
That's correct.
And why is that?
Because there's just, really, it's kind of beyond a departure of standard of care. I mean, it's something that we would never even fathom doing. Really, any reasonable person managing someone with insomnia to be using propofol for that is really, there's really no reason for that.
You concluded that Dr. Murray acted with gross negligence and with an extreme departure from the standard of care, and that through his acts and omissions, he caused Michael equipment, abandoning his patient, allowing access to drugs, lying to medical personnel, and delaying in calling 911. In either scenario, Conrad Murray played a direct role in causing Michael Jackson's death. Those are your findings?
That's correct.
And would you agree that even under a scenario put forth by the defense that Michael Jackson self-administered either lorazepam or propofol after being given the drugs by Conrad Murray in this setting, that the risk of that happening would be a foreseeable thing that a competent doctor should have been aware of.
Oh, absolutely. I mean, you know, here you have a patient that potentially may have substance abuse problems, or clearly it sounds like he had substance abuse problems, and you're providing this environment where drugs are readily available. They're not locked up. They're at an arm's reach. That is definitely a foreseeable complication. And when you have potent drugs, which in combination, as we talked about, can synergistically have such profound effects that we've discussed at length, that is very foreseeable.
And would you agree in a broader sense that when administering benzodiazepines and propofol, even a 25 milligram administration of propofol in this setting, that the risk of respiratory depression and cardiovascular failure is, again, a foreseeable risk that any competent doctor must know about?
I think this goes to the fact that there were many issues that together culminated in this: the underlying dehydration, his underlying condition, the synergy, the combination of those medications, the benzodiazepines and the propofol. Absolutely, and that was something that that was definitely a possibility.
And would you agree that respiratory and cardiovascular complications is a known and foreseeable and normal risk when you're administering benzodiazepines and propofol?
That's correct.
Thank you, Doctor. Nothing further, Your Honor.
Thank you, Mr. Walken. May I see counsel, please? With the cross-examination of Dr. Kamangar. And Dr. Kamangar, rather than keep you waiting out here, I'm going to excuse you and remind you that you're not to discuss your testimony and facts in the case with any other witness until the trial is over. I'm going to ask you to join us tomorrow at 8:45. Okay, you can step down, sir. Excuse you for the rest of the day. You want to take your reminder? All right, ladies and gentlemen, before I provide you with the all-important adjournment instructions, I want to let you know that because of scheduling-related issues, we are